Good afternoon. I'd like to welcome you to the final but very exciting session of the day, during which we will hear first-time results of clinical trials. I'd like to invite the panelists to please come up and join me at the table. And I'd ask our first speaker, Dr. Carl Regillo, to come to the podium. Carl will be sharing with us 12-month results from the Phase 2 DAVIO 2 study.
Thank you, Ingrid, and thank you to the program committee for the invitation to present for the first time the end of study DAVIO 2 Phase 2 study results. Here are my disclosures, and relevant here is research support and consulting with iPoint. EYP-1901 is vorolanib, a potent TKI, tyrosine kinase inhibitor molecule that has pan-VEGF properties, and that's combined with a bioerodible intravitreal insert for intravitreal injection. And this was designed to provide therapeutic levels of vorolanib in a control-release, sustained delivery, zero-order fashion over at least 6 months. DAVIO 2 was a Phase 2 clinical trial that assessed the efficacy and safety of EYP-1901 versus aflibercept in patients with previously treated wet AMD. And to be included in this trial, patients had to show a demonstrated response to anti-VEGF therapy, had to have at least 2 injections within a short 6-month time frame before enrollment, and these visual and OCT criteria as listed. This is a 3-arm study. It enrolled 161 patients. You can see 2 doses of EYP versus the control arm, which is standard 2 milligrams aflibercept. All 3 arms had monthly loading of aflibercept. Aflibercept carried on in the control arm is fixed Q8 weeks for the course of this study. And EYP was injected, it was a single intravitreal injection, one of these 2 doses, at week 8, the end of the loading phase. All arms in this study could receive supplemental aflibercept based on the listed supplemental pre-specified criteria, in addition to investigator discretion. The primary endpoint, this was a non-inferiority study, so it was mean change in BCVA from baseline. To the primary endpoint here is weeks 28-32, that's 7 to 8 months, which represents 6 months from the single intravitreal injection of EYP. Study carried on to the end, which is actually 14 months or 12 months from the EYP injection. So baseline ocular and patient characteristics, very well balanced among the 3 arms, as shown here. Again, previously treated, so these patients came in with relatively good visual acuity, averaging about 20/32, and very high frequency of treatments in the previous 12 months, averaging 10. So the visual outcomes shown here. This study with EYP at both doses met its primary endpoint, with both doses being non-inferior statistically to aflibercept Q8 week dosing in the maintenance phase to the primary endpoint as shown here. Nearly identical visual acuity curves to within a letter at the primary endpoint, 6 months after EYP injection. Here we are 12 months or 10 months after EYP, holding very well. And again, all the way through end of study, 14 months actually averaged here visual acuity 13 to 14 months, 12 months from the single EYP injection. Similarly, anatomically with OCT outcomes, central subfield thickness is shown here, looking stable after the loading phase with both EYP doses, maybe a hint of a dose response to the primary endpoint. Carried on, very stable to 12 months, and then right to the end of study, month 14, again, 12 months from the single EYP injection. Note very stable, minimal to no significant fluctuation in the 2 EYP, and for the aflibercept, we've come to expect that sawtooth pattern with fluctuation as shown there. So in this study, as I mentioned, all arms could receive supplemental injections. So all eyes were assessed for meeting supplemental treatment criteria, and that includes the aflibercept control arm, which is shown here. So here's the proportion of patients not meeting the criteria, but what you're seeing by the end of study, about 1/3 of patients actually met and or received supplemental criteria and supplemental treatment with aflibercept. So in other words, about 1/3 actually broke through Q8-week dosing and reflects a very high need for the types of patients enrolled in this clinical trial. So here now are the proportion of eyes in the 2 EYP arms, essentially identical, over the course of 6 months from the EYP single injection, 2/3 without any supplemental criteria being met or any supplements at all given, Then at month 12 and month 14, carrying on at month 12, just over half or about half of patients were not supplemented. And at month 14, again, 12 months from the single injection, about 46% were not supplemented. Treatment burden. This is treatment burden within the course of the clinical trial over 12 months, right after the load. This is the total number of treatments. You can see a 70% reduction in both EYP arms compared to the aflibercept, and this includes those supplemental injections in all three arms. And then looking at treatment burden compared to the prior 12 months, again, you see very frequently treated patients on average, most of them are. In the two EYP showing the swimmer lane plots, you can see individual patients before and after enrollment, and over 14 months or 12 months after the injection, we're seeing an 80 to 81% reduction in annualized treatment burden compared to pre-enrollment, and there's the 46 and 43% injection-free up to end of study. As for safety, EYP, both doses very well tolerated over the course through the end of the study, 14 months. No EYP-related ocular SAEs or systemic SAEs, no implant or insert migration into the anterior chamber, no cases of retinal vasculitis or occlusion, no discontinuations related to EYP. 97% of the AEs are very mild, a few moderates, and generally related to what we would expect or get with a simple intravitreal injection. So in summary, with DAVIO 2, this is the largest intravitreal TKI trial to date. EYP 1901 at both doses with one injection maintains stable visual acuity and anatomic outcomes over the course of those 14 months. For regarding supplemental free injection time frame, 63% at 6 months, 44% 12 months after the single dose, and a great reduction in treatment burden of 80% or more over the 12 months compared to pre-trial, all being very well tolerated. And with that, I'm pleased to announce that the phase 3 program is about to commence, effectively almost any day now, expecting the first patient to be enrolled. This is a 2-arm study. These are global registration non-inferiority trials comparing single dose of EYP, aflibercept, same control. Here, however, EYP is being dosed every 6 months, primary endpoint non-inferiority to that blended 52, 56 weeks. So very excited to see that in the future. Thank you.
Thank you very much, Carl. Yes. Our next speaker is Dr. Charlie Wykoff, who will be sharing extended results from the AMARONE trial.
Thank you, Dr. Scott. It's great to be here with all of you. And on behalf of my co-investigators, it's great to be able to present updated data from the AMARONE trial today for the first time. I'm a consultant for iBio and Merck. Many of our common retinal diseases are defined by pathologic exudation, including wet AMD, DME, diabetic retinopathy, and RVO. And there's a need for new mechanisms of action to restore and maintain an intact blood-retinal barrier. Toward that end, within the Wnt pathway, Norrin signaling can drive stability of the blood-retinal barrier. Norrin is a highly specific diffusible ligand that's produced by Mueller cells that binds to a multi-component receptor complex, including Frizzled-4, that is expressed on retinal vascular endothelial cells and requires clustering for activation. Following activation, this leads to stabilization and nuclear translocation of beta-catenin that leads to transcription of a set of genes responsible for maintenance of the blood-retinal barrier. With the goal of activating this highly conserved and specific pathway, Restoret was engineered as a Norrin mimetic and Wnt agonist. Restoret itself is a tetravalent, trispecific antibody that binds 2 different LRP5 epitopes, as well as Frizzled-4 through 2 separate FABs, all of this joined by a central Fc domain. This 200 kilodalton antibody leads to receptor clustering and downstream transcriptional activity. AMARONE was a phase 1b/2a trial. Part 1 was an open-label, multiple ascending dose component in which 12 patients were treated with 4 ascending doses of Restoret. Part 2 was a dose-finding randomized component in which 21 additional patients with DME were treated. In both Parts 1 and Part 2, all patients were treated with 3 monthly treatments. DME patients given Restoret monotherapy without any anti-VEGF injections. Neovascular AMD patients given Restoret plus aflibercept at each point. Following Part 2, 9 patients enrolled in a prospective safety extension study at 5 participating AMARONE trial sites, during which 3 additional monthly treatments were given for a total of 6 monthly treatments. Again, all DME patients in this trial through the full 6 months here were given Restoret monotherapy without anti-VEGF agents, and the Neovascular AMD patients were given combination therapy of aflibercept plus Restoret at each of those time points. The primary objective here was to assess safety and tolerability, and secondary objectives included assessing functional and anatomic outcomes. Now let's look at results. 26 and 5 patients with DME and neovascular AMD were enrolled, and baseline characteristics were typical for these disease states, with average visual acuity about 20/63 and 21/25, and mean CST of about 500 microns in both populations. 31 of 33 patients completed Part 2. During Parts 1 and Part 2, there were no rescue therapies given, and across a total exposure of 97 Restoret injections given, there were no drug-related adverse events, no IOI events, and all of the adverse events for all of the patients are shown in the table to the right. During the safety extension study, 26 additional injections were given to 9 patients, with 1 patient missing 1 injection visit. Identical to Parts 1 and Part 2, there were no drug-related adverse events, no IOI events, and no rescue injections given. Here is longitudinal change in best corrected visual acuity for all of the DME eyes, showing a gain of 7.2 mean letters at week 4, increasing to 11.2 mean letters at week 12. Anatomic improvements were also observed, with mean CST improving from about 500 microns to 350 microns at week 12, again without VEGF inhibition. This corresponded to 80% of patients achieving a CST of less than 300 microns by week 12. This plot of each patient's individual CST shows that all participants had improvements in CST at week 12, again with Restoret monotherapy, with 2 outliers with persistent CST of greater than 500 microns at week 12, both of which had improved 100 microns or more from baseline. Here are 2 case examples. This is the first patient that I treated in this clinical trial, a 49-year-old male who experienced resolution of intraretinal and subretinal fluid and a gain of 13 letters through week 12. Here's a second, more severe disease at baseline, 68-year-old female who had improvement in intraretinal and subretinal fluid with some residual fluid and a CST of 308 at week 12 with a gain of 9 letters. Summarizing the DME data, all of the doses have appeared effective with a mean change in visual acuity of 11.2 letters at week 12, with continued anatomic improvement with monthly dosing through week 12 and 80% of patients achieving a CST of less than 300. Looking at the neovascular AMD data, recall the distinction here is that patients were treated with combination therapy and not just monotherapy. All these patients at each time point received both aflibercept and Restoret. Again, all doses appeared effective, and here mean CST improved from over 500 microns at baseline to all patients achieving a CST of less than 300 microns within 4 weeks, and a mean change of 6.8 letters gained at 3 months. To finish, here are 2 neovascular AMD cases. This 84-year-old female had improvement in her CST from over 700 microns at baseline to 270 microns at week 12. And this 91-year-old female had flattening of her PED, an improvement in her intraretinal fluid and subretinal hyperreflective material with a gain of 7 letters at week 12. In conclusion, across the AMARONE Phase 1b, 2a, and safety extension study, Restoret, a norm mimetic and Wnt agonist, was well tolerated without safety signals across 123 total injections. Fascinating structural and functional improvements were observed, particularly notable among DME patients treated with monotherapy. This suggests that activation of the Wnt pathway, specifically through Frizzled-4, may be a potentially effective treatment for the treatment of multiple retinal vascular diseases independent of anti-VEGF agents. Looking forward, the pivotal Brunello trial among eyes with DME, a 2-year multi-center randomized double-masked trial comparing Restoret monotherapy to anti-VEGF therapy, is ongoing, with a primary endpoint of mean change in best corrected visual acuity from baseline to 1 year. Finally, I would like to thank all of my co-investigators and, most importantly, our patients. Thank you.
Thank you very much, Charlie. Our next speaker is Dr. Christine Nichols Kay, and she will be sharing some interim results from the ATSN-201 dose escalation study in patients with X-linked retinoschisis.
Thank you very much to the organizers of So Special Today for inviting this talk. Again, I'm Christine Kay. I'm a vitreoretinal surgeon, IRD specialist in Gainesville, Florida at Vitreoretinal Associates. Today I'll be presenting interim safety and efficacy of ATSN-201 dose escalation study in patients with X-linked retinoschisis. I'd like to thank the Atsena Therapeutics team as well as the investigators and surgeons involved in treating these patients, Leslie Everett, Aaron Aguil, Byron Lamb, Dr. Lauer, Barra, Colin Grigori, and the Atsena team. These are my financial disclosures. I'm a consultant and advisor for the Atsena Therapeutics team. X-linked retinoschisis is an X-linked inherited retinal dystrophy. It's one of the most common causes of juvenile macular degeneration in males. It's caused genetically by mutations in the RS1 gene that results in loss of visual acuity due to splitting of the layers of the retina and increased risk of retinal detachment and vitreous hemorrhage in these patients. RS1 encodes a protein retinoschisin, or RS1, which is expressed importantly in the photoreceptor cells and to a lesser degree the bipolar cells. RS1 plays an important role in cell-cell adhesion and fluid balances and the photoreceptor bipolar cell synapse. This is a photo of an OCT, a pathognomonic photo of an example of XLRS OCT. ATSN-201 is a subretinal gene therapy. It's AAV-mediated, introducing a functional human retinoschisin gene. The human rhodopsin kinase promoter target was chosen to target photoreceptors as they need to be targeted in this gene therapy. And importantly, the AAV-SPR capsid, which has been shown in preclinical models to spread 7 to 12 millimeters of transduction past the edge of the bleb, was chosen to allow that transduction to spread past the bleb, to allow small, careful placement of these subretinal blebs in this X-linked retinoschisis condition. This is the phase 1/2 clinical design. Today I'll be presenting a data cutoff of September 4, so recent update in 2024 September update. What I'll be presenting today is 6 patients who have been treated, low dose of n equals 3 of 1.5 e to the 10, and a high dose of n equals 3 of 5 e to the 10. Cohort 1 and cohort 2 have been completed and are continuing follow-up. Median age, cohort 1 was 21, cohort 2 was 24. Visual acuity medians were 2050 in cohort 1 and 2100 in cohort 2. Inclusion criteria, of course, these were X-linked retinoschisis confirmed genetically patients with pathogenic mutations in RS1, BCVA between 2040 and 2200. It did require presence of foveal schisis or parafoveal or juxtafoveal schisis in the study eye and OCT. The primary endpoint, of course, in a phase 1/2 is safety, dose-limiting toxicities, and treatment-emergent AEs at 52 weeks. Secondary endpoints that were important were OCT, structural endpoint, and the mesopic microperimetry for a functional endpoint. The drug was administered via pars plana vitrectomy in a single subretinal injection. This was actually 2 blebs. We had a 150 milliliter microliter dose. 275 microliter blebs was the goal. Surgeons were instructed to not detach the fovea, but to treat above and below the fovea to treat the macula, but avoid that fragile foveal area and avoid foveal detachment. Corticosteroid, there was a 7-week prednisone taper, 1 mg per kg tapered over 7 weeks, 20 mgs of STK at the time of surgery, 250 milligrams of IV methylprednisolone at the time of surgery, and a typical 28-day topical Pred Forte topical steroid taper. This was in this safety summary update overview. There were no dose-limiting toxicities and no instances of macular hole formation or retinal detachment. There were 53 TAEs, majority grade 1 and 2 in severity. Cohort 2, which I'll focus on today, this high-dose cohort, there were 3 AEs of subretinal small deposits and retinal thickening, and 1 TAE of an epiretinal membrane in a patient that required significant intraoperative laser due to finding of lattice and a horseshoe tear with significant intraoperative laser. No subjects were discontinued from the study, and there were no treatment-related SAEs. There was 1 SAE in the study of a fever of unknown origin requiring a hospitalization workup, and this was in a 7-month post-treatment case, so not related to surgery or to IP. Efficacy-wise, there were 4 of 6 treated patients who had closure of their foveal schisis at their most recent visit. You can see on the bottom the time point, month 12, month 6, month 6, month 3, along the bottom row here. And importantly, the untreated eye did not have that same effect. So you can see the residual schisis still in the untreated eyes. And this was seen in 2 of the 3 cohort 1 patients and 2 of the 3 cohort 2 patients with that higher dose. The majority of treated eyes showed reduction in central retinal thickness. You can see the red eyes that were treated, the black eyes are untreated. A designates, a little tiny letter A, if you can see it, designates the closure of foveal schisis time point. So in that subject 1, that occurred at 9 months. Any patient that had closure of foveal schisis had durable effect of that foveal schisis to the last point in follow-up. And very importantly, eyes that had the structural improvement did show functional improvements, and that was by mesopic microperimetry. Here, the red circles are the areas of the bleb that were gained from the surgeon's drawings as well as the intraoperative photos. So you can see in subject 1, 3 blebs were actually created. Sometimes a temporal bleb was created if we were encroaching on the fovea and wanted to avoid foveal detachment. But typically 2 blebs, as in subject 3, is a very common pattern for surgery above and below along that ST and IT arcade. And you can see the improvement in the microperimetry correlating to the patients who had schisis improvement. Majority of eyes did show stable visual acuity across the trial. So in summary, ATSN-201 is an AAV-mediated gene therapy, subretinally delivered to introduce functional human retinoschisin gene photoreceptors. Safety, this low dose of 5E10 was well tolerated up to 1 year. The high dose of 5E10, because of these 3 of 3 patients with subretinal deposits and retinal thickening, it was opted to move to a dose de-escalation for cohort 3 to an intermediate dose of 3E10, which is currently being investigated with patients being treated in cohort 3. Only 1 SAE in the study unrelated to study drug or procedures, no DLTs. Efficacy, there was preliminary evidence of efficacy in both the low dose and the high dose cohorts. Majority of treated patients showed reduction in central retinal thickness, with 4 out of 6 patients with schisis closure. The 2 patients that did not have this substantial decrease, 1 patient had blebs that were far outside the arcades and we think did not have a chance to have that transduction. And this also was a patient who had some mild inflammation due to a high weight, body weight, and underdosing of oral steroids. The other subject developed an epiretinal membrane that I had mentioned, which probably combated the ability for schisis closure. Improvements in retinal sensitivity were observed in all patients with foveal schisis closure. Thank you very much, and trying to click to my conclusions, but that's the end of the talk. Thank you very much for your attention. Take care.
Thank you. Our final speaker in the session this afternoon is Dr. Rishi Singh, and he will be sharing results from the Phase 2/3 SIGLEC trial.
Thank you for the organized committee for allowing me to give this talk. Here are my financial disclosures for this presentation. We're well aware from some of the previous studies that have been presented today that the complement system is very involved in geographic atrophy. And one of the other components of this is the macrophage overactivation, which occurs within these conditions. The inflammatory activated macrophage can cause both dry macular degeneration through the release of cytokines, as well as angiogenic proteins that can be released, causing neovascularization. Resolution of the macrophages in a quiescent state may be an opportunity to cause these macrophages to go into a repolarization phase, and thus might be a therapeutic for geographic atrophy. SIGLECs are cyclic acid binding immunoglobulin-like lectin receptors. These are the outside coats of essentially macrophages, and they're the barcodes of these macrophage cells, which allow them to recognize other cells as either self or non-self. And potentially the component here of ABD104 can bind to these SIGLEC receptors and go into a repolarization phase of these macrophages to then affect the microglia and the macrophages into this healing state. ABD104 also binds complement factor H and stops the amplification of C3. ABD104 is a 20 kilodalton size protein. It is a nanoparticle coated with high affinity polysialic acid ligands. The junctional zone has also become important in geographic atrophy. We've learned a lot about this from the recent studies. This is the area between the edge of the geographic atrophy where we have dead RPE cells and the healthy tissues surrounding it. In this junctional zone, we know we have inflammatory microglial cells, we have active macrophages and MAC attack complex observed histologically, and these cells in this area really are injured but not necessarily dead at this point. So potentially stabilization of the structure as well as rescuing these damaged cells might lead to functional improvements. ABD104 inhibits inflammation, repolarizes microglia, and thus may be a therapeutic option with a functional benefit. In the SIGLEC Phase 2A U.S. clinical trial, this was the first human study with single-dose safety. There were 4 cohorts tested, anywhere from 0.1 milligrams to 3 milligrams within the study, in a dose escalation format after a 1-month observation period to observe for any side effects. The primary endpoint was at month 3, which is the safety and tolerability, both ocular and systemic, of the dose-limiting toxicity of these drugs. There were a variety of secondary endpoints looked at, including the change in best-corrected acuity, geographic atrophy by fundus autofluorescence, imaging biomarkers as well were looked at. These patients had bilateral geographic entry and entry with best-corrected acuity of 2080 to 2200. The lesion size must be larger than 1.25 millimeters squared. Here's the baseline characteristics of the groups in the population. Just to point out, these patients had, in the study eye, poor vision, anywhere from 2160 to 2200 visual acuity, and the fellow eyes also had geographic atrophy and vision impairment as well. This is the primary endpoint of the study, which is the ocular side adverse events. There were no dose-limiting toxicity observed in the trial. There were no incidents of ischemic optic neuropathy, retinal vasculitis, or increased IOP during the study period. And a single intraocular inflammation event did occur in the highest dose cohort, which is the 3 milligram cohort. This occurred on day 1. It was observed. There was no treatment added, no steroids given to this patient, and it resolved by day 15. Incidentally, in this patient, the best-corrected acuity was measured at 13 letters gained from baseline at day 15. On the left side, you see all of the dosing cohorts and their effect on the geographic atrophy growth rate within those populations. And you can see the 1 milligram and 3 milligram group had a significant decline in the rate of geographic atrophy compared to the other dosing cohorts tested. On the right side, you see the highest dosing cohorts, 3 and 4, in comparison to the fellow eye, to show you that there was a reduction seen as early as month 3 in the growth of geographic atrophy within these cohorts. Looking at this junctional zone activity, we could look at that by the measurement of both hyperautofluorescent decreases within that area. And what we found in that population when you looked at cohort 3 and 4, there was a significant reduction in the autofluorescence within that population of cells within that junctional zone, or stability of that autofluorescence within that junctional zone in 78% of patients in the study. Here's the visual acuity results from the study, which show that 40% of patients actually had a gain of visual acuity of 5 letters or more after a single AVD-104 injection. And when you compare that to the fellow eye, you can see a 5.2 letter gain in the study eye compared to the 1.7 letter gain in the fellow eye in cohort 3 and 4 within the trial. This is going to now lead into a phase 2b/3 study, which is currently enrolling. It's a head-to-head clinical trial that is currently fully enrolled. It has AVD-104 given in a 1 milligram format monthly versus AVD-104 in a 2 milligram form given every other month, compared to its active comparator, which is avastin-capsid pegol given monthly. The primary endpoint for this trial will be the rate and change from baseline in areas of geographic by fundus autofluorescence at 12 months. In summary, SIGLEC study phase 2A was a U.S. clinical trial that showed excellent safety with no dose-limiting toxicity out of 3 months after a single injection. The patients who received an injection of 1 milligram and 3 milligrams experienced gains of 4.8 and 6.5 letters from baseline, respectively, at 3 months after a single injection. The patients in this higher dose cohorts also demonstrated a 48% reduction in GA lesion growth rate compared to the fellow eyes at month 3. And 78% of these patients also experienced a junctional change in the autofluorescence profile seen within that cohort as well. So seeing these functional benefits and the efficacy within geographic atrophy is very promising. And again, the larger phase trial is currently fully enrolled, and we'll hear results of that shortly. I want to thank you all for your attention.
Thank you very much. Thanks again to all the speakers for their outstanding presentations. Can we put up the panel discussion slides, please? All right, I'd like to welcome and introduce the panelists, Dr. Robert Bissacool, Odette Houghton, Sobha Sivaprasad, and Jay Chablani. Thank you all for agreeing to serve on the panel. These are my disclosures. So I'd like to get the panelists' insight related to this presentations that we just heard. The first question: the current anti-VEGF monotherapies impose a high treatment burden. With new therapies offering extended treatment intervals, how do you think patient monitoring and visit frequency will be managed, particularly during the initial phase of treatment?
Should I get started?
Jump in.
All right. Thanks, Ingrid. So we all are seeing very exciting times that, we are able to extend the treatment-free interval for these patients. However, I personally like to follow them up a little closely in the beginning. Before offering them anything, we would really like to see if the new implant or new treatment is equally effective or not. So this is what we learned even with when the DEX implant was introduced. So I usually like to see them initially almost monthly like we did for anti-VEGF. And then once we gain some confidence, then we can eventually start extending it. And that's what I explained to my patient, that the first 6 months we will still be seeing how the new treatment is being offered. And then eventually we will extend, because these treatments are going to go for years. And once we gain the confidence that this particular treatment does a great job for you for say 4 to 6 months or longer, then we can certainly extend it.
Okay, thank you. Although anti-VEGF monotherapy is the first-line treatment for wet AMD and center-involved DME, new therapies are emerging with different mechanisms of action, as we just heard. Do you think that these will be used as monotherapies or in conjunction with anti-VEGF treatment, followed by maintenance with these therapies? In other words, how will these new therapies fit into our treatment paradigm?
Well, I think it's wonderful that we're going to have some different mechanisms of action to work with. And so the first answer to this question is, how different is the mechanism of action? I think in the context of the clinical trials, a lot of times we are looking at these new agents as a monotherapy, just to more clearly delineate what their effects are as separate from anti-VEGF. But in the real world, I don't think there is any reason for us to think that the next modality that comes on has to supplant anti-VEGF. And so I think there will be patients where we will combine the two to try to get the maximum effect.
Okay. If the Restoret data are confirmed in the later stage trials, how do you envision this new monotherapy impacting our current DME treatment paradigm?
I can answer
Any
that
of you.
question. Yes. Well, it's clear to us all that we're still in the first inning of the DME treatment, of pharmacological treatment of it. And we have many medications, but they are suboptimal, and they require frequent treatments, and patients don't like it. So in this light, what stands out to me is the durability of Restoret. Patients may have the potential to not need as frequent injections. And in addition, the visual acuity improvements, the anatomical improvements, and the possibility of being able to address the tachyphylaxis is also very impressive. But we all know that in the beginning, these early-stage clinical trials seem really exciting. However, they don't always pan out in the real-world data. So we still have to remain circumspect, and as we get more information and more data in the later clinical trials.
Given that Restoret has a completely novel mechanism of action, are there any particular areas where you would envision differentiation from anti-VEGF standard of care?
Yeah, I think you just described about patients who are not responding to anti-VEGF agent. And of course, then we turn towards non-VEGF driven pathways, and this will be one of them. We have always only had steroids, and perhaps newer agents presented, today on anti-IL-6, and Restoret, kallikrein pathway. These are all new ways by which we will attempt to get our patients' macula dry as much as possible.
Great. Do you think that the SPR spreading vector being investigated for X-linked retinoschisis could be used in other subretinal gene therapy programs? And if so, in which programs or diseases do you think it would be most useful?
Okay, my turn. So the results which Christine presented was really exciting, and I think that the company is already expanding their use in LCA as well as in Usher. I think some of the results are really exciting, and we look forward to hear more and more about it. And this is really great times.
What are your thoughts on the relative risk of vitrectomy in the X-linked retinoschisis population, and what surgical factors should be considered specifically in these patients?
Yeah, right. We have, in the previous subretinal injection trials, we've made a very big point of making sure that posterior hyaloid is completely elevated and removed so that we can get a good subretinal injection, and so that we don't have any risks of having membranes contracting on the surface at the injection site and causing retinal detachment. First of all, in children, inducing a complete PVD is more difficult, and In this population, particularly, there might be risks of, say, unroofing the schisis area, with detrimental effects on the vision. So I'd like to really hear it firsthand from some of the surgeons that are doing this in the study. What sort of measures are they taking to address this? Are they able to get a good subretinal injection without doing a complete posterior hyaloid separation?
So Dr. Singh talked a little bit already about the anatomic state of retinal tissue in the junctional zone. Do any of you have anything to add about what is known about this area in the retina in our patients with GA?
Yes, the junctional zone is the border of the geographic atrophy, as Dr. Singh said. It's an area that is of interest to study retinal degenerations and also to look for potential new therapeutic strategies. There's 3 types of junctional zone, depending on the RPE and the photoreceptor defects. So the RPE defects and the photoreceptor defects can be exactly corresponding, and that's type 0. Type 1 is the most common, and that's where the RPE defects, the photoreceptor defects extend beyond the RPE defects. But the most interesting one is where there is actual preservation of the photoreceptors, which is type 3, and it's the preservation of the photoreceptors extends beyond where the RPE defect is. So that raises the possibility of us being able to look for cell-based therapies for geographic atrophy.
Okay, so we're running out of time. Very last question. Among all the exciting new therapies we've seen today, which of these agents are you most eager to see additional data from and why?
Is that to me? Well, they were all 4 exciting presentations. I think there's a lot of eagerness about the TKI inhibitors at present, and I think we like to see more data, as well as hearing all these presentations. I was thinking, in clinic, which patients will I put these drugs onto? Because in the trials, they were all high treatment burden patients, and I would dare not put them on that and then not see them for the next 6 months. So will it reduce burden of injections? Yes. But will it reduce monitoring visits? Unlikely, unless we have home OCTs, as we heard this just now as well. So things are evolving. Yeah, I think we'll know.
I'm sorry our time is so limited. I would like to thank all the panelists. Thank you very much for your insight. Thanks again to the speakers, and a big shout out to the program planning group for organizing a fantastic meeting.